of the knee. A few disclosures. I'm a consultant from BioClinica, book royalties from Elsevier, a grant from AIUM, and research equipment from Harvest Technologies. So let's talk briefly about the sonographic technique of the knee. We covered this somewhat in the demonstration, but I want to emphasize a few points. One thing is to consider focus versus a comprehensive evaluation. Of course, when you have a focal clinical problem, you can focus your evaluation to just one area, but make sure that when you cover the one area, you cover all those structures in that one target area. At our institution, we prefer a more comprehensive evaluation. Every knee patient who comes in for an ultrasound is imaged the same way, anterior, medial, lateral to posterior, so that as a radiologist, I know the imaging sequence that the technologist will save for me, and when I go into scan, I would do the same thing. What's nice about that is my technique, I get to practice that. Also, you have a true understanding of normal anatomy, so that when you have to look at a structure, you're comfortable knowing what it looks like. Also, by looking at normal anatomy all the time, you are able to pick up subtle abnormalities even better. Now, if someone has anterior knee pain, of course, you'll probably spend 80% of your time on the anterior part. When you're looking at the other structures, you can do this in a matter of minutes when it's normal. And also the last point is you could have a referred pain. And so I approach an ultrasound like I do an MRI. If it says rule out Achilles tendon tear, I'm going to look at everything on every image. I'm not just looking at the Achilles. The same thing holds true with ultrasound. Usually the transducer size, the megahertz is 10 megahertz or greater, because the structures are very superficial. So I'm going to briefly talk about anatomy and then move right on to pathology, which will be most of the slides.